Right. Welcome everyone back to another virtual shouting session at Hearts for Health. We hope your week has started off well. Today being a Monday. And today we're going to be joined by Dr. Curseen. She is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare and serves as the Director and the primary care provider for the Supportive Oncology Clinic at Winship Cancer Institute. So definitely a physician leader of today. And I think this is going to be our first session talking about palliative care. So I'm excited to bring her on to talk about a new specialty for many of you. Sometimes it might be one of your first exposures, and hopefully some of y'all catch an interest for the specialty that is palliative care. I do have a few reminders for those listening, especially if you're new. For those who already know about us, this probably sounds familiar. But towards the end of these sessions, we do have a Q&A. That Q&A will take place during the last 15, 20 minutes, or however long we have once Dr. Curseen wraps up her presentation. To have your questions in for that Q&A, you just need to type them into the chat. That chat feature is the same one that you'll see on either the side or the bottom to the video that you're watching here. So just type them in and we'll take them in as they go through in the order that they go through. Also, for those who want to stay updated with future shadowing sessions, we use two platforms really to get the word out about our flyers and about upcoming shadowing sessions like this one. We use our Instagram page where we post flyers, and that includes their date, the time that those sessions will be, more about the speaker, the specialty. So you probably heard about this session through our flyer over Instagram or through our listserv, which is our second way that you can get in touch with us. It's an email listserv. We send it out weekly. And in order to be added onto the listserv, you can either do that through one of two ways. You can go onto our website, go onto any page of the website, scroll all the way down to the bottom, and on the left-hand side, you'll see a subscription form. Fill it out, click submit, and you'll be good to go. Another way to do that is just manually emailing us at shadowing.h4h@gmail.com. Include your name, include your email, and send it over, and then we can manually add you onto the listserv. Again, these are just ways that you can stay in tune with our programs, mostly virtual shadowing, but also others. But yes, that's all that needs to be said in terms of reminders. If you do have any questions outside of the ones that I just mentioned, please let us know. Just shoot us an email and our team will be happy to get back to you with answers. But with that said, I don't want to take up too much time. So Dr. Curseen, feel free to take it away.
Hi, thank you so much for hosting me tonight. And I'm so happy to be here to talk about something I love personally, palliative care. So we'll go ahead and jump right in. I'd just like to let you all know I have no relevant disclosures. So I like to, I think it's always important to try to make this real, to give you a really good understanding of what me and my colleagues do. So I'd like to start off with just sort of getting you guys in the right frame of mind about the kinds of patients we see and what we can do for them. So what do these people have in common? A 30-year-old mother of three and with 3 children under 10, who has advanced breast cancer, who works as a pastor. A 55-year-old with diabetes needing a heart transplant, has constant burning in its feet, and he's currently homeless. A 92-year-old with advanced dementia who's being cared for by her only adult daughter, and a 5-year-old with aggressive leukemia being raised by his grandmother. So, what do these patients have in common, and why might patients like these cross my path? Well, they all have serious and life-limiting illnesses. They all need more than just the illness treated. And they all have caregivers or families who are affected by this illness. So that brings us to what exactly is this thing called palliative care? Why would somebody like me or my colleagues be involved in these patients' lives? Well, to start with our common definition, palliative care is the medical specialty that focuses on people who are living with serious illness. It focuses on providing relief from the symptoms and the stress of that serious illness, no matter what the diagnosis is. And the goal primarily is to improve quality of life for both the patient and the family. Palliative care is provided by a team doctors, nurses, and other specialists who all work together with a person's other doctors to provide them an extra layer of support. It's appropriate at any age, any stage of the illness, and can be provided with curative treatment. So I always like to think of this word cloud when people ask, what does palliative care entail? These are all of the things that we entail: full peace, planning, compassion, caregiving. So just to illustrate it a little bit more, kind of when, patients sort of are going through something difficult, a Mack truck has run through their lives. They get a serious diagnosis. Their loved one is diagnosed with something. It's almost like they're sitting on a bridge and all of these things are coming at them: treatment options. Their lives have changed. They're not only are they dealing with their health, but they're also dealing with what's happening to them personally, socially, how they move through the world. Just everything changes, even financially. And so they have plenty of things coming at them. What we are and where we're most helpful is that we try to help hold up the bridge and provide the support for the patient and also the medical system to help get the goals accomplished. So I'd like to show you a little video because I think that these often explain it better than I do. We'll go ahead and start.
What is palliative care?
It helps keep me going all the way down the coast.
It gave Nan a little more energy.
And I'll blow your house
So she can still read to me.
It's available early in your diagnosis,
It's not looking good, Artie.
even if you've still got a few rounds to play.
Pretty big bunker.
It gave me the chance to do more of the things I enjoy the most with my best friend. What a good boy. Palliative care. It's more than you think. What is?
So, so the video kind of shows, what our philosophy is, but I want to drill down a little bit more. So what are we? We are the service that specializes in helping. We help patients achieve their goals and assist them with the things that they need. We specialize in hoping. We help explore what patients are hoping for. And we also help them reframe the hope when the clinical condition changes, because that's incredibly important. We support what they're wanting. And then sometimes when life throws a curveball, when the illnesses aren't going the way they hope, we try to help them find new hope in the life that they have and to continue to have meaning. We're holistic. We help focus on patients as individuals. We see people as emotional, spiritual, and physical, all of their components together. And we value that human complexity. We sit in that complexity. And that's what helps us tailor their care. And sometimes we facilitate healing. I like to explain that people can usually tolerate pretty difficult treatment, but they don't need to be miserable while they're getting that treatment. And oftentimes when we're there to help, we are actually a part of that healing process for patients who are going to have a serious illness in the hopes to get better. So kind of what is that So what is our philosophy? Well, palliative care is about goals. Like, what is the goal? We as healthcare providers, we serve as guides. We have a willingness to allow patients and families to decide how they think their shared care should be. And then we work through the uncertainty together. So what part of the medical system do we operate in? Where do we come in? We come in where there's medical uncertainty, right? Where it's not entirely sure how things are going to be. It's not entirely sure how all of these things are going to come together for you. And we help you sort them. We sometimes sit in the space when medical evidence fails. So when things aren't going according to plan, we still figure out a way to provide comfort and to provide medical care. And we also do that in a flexible manner based on the patient and their goal. And we are where the patients are. We meet people where they are. So what's the model of care? Well, what are we actually doing? Well, our primary goal is to mitigate suffering. We treat their distressing symptoms as entities in themselves. So if you have heart failure, how we might be helpful in heart failure, we may not be treating the heart failure, but we're certainly going to treat the shortness of breath, the weakness, and the fatigue. And those rise to the top just as much as the primary diagnosis when you see us. So your cardiologist is managing your heart failure, and that's amazing. We manage the things that the heart failure is actually doing to you. And together, we help patients try to reach wellness or try to figure out a way to live with what they're going through. Therapy is medically indicated if it controls symptoms. So it's if you like it, we love it care. Anything that's going to help you reach your goal and control symptoms, it falls under the guides of palliative care. We view, as we said before, you in all of your complexity and all of your dimensions, because the more we understand about you and know about you, that helps tailor what recommendations we make, and we know how to advocate and also assist you with reaching your goals. The treatment is congruent with the values and beliefs and the concerns of the patients and families. So we take what your values are and what your the way your culture and how you move through the world and how you see yourself and whatever you are valuing, that's how we tailor what we are doing. And we accept that and support that. We enable a patient to live fully and comfortably, and we value measurable data like your labs and all those things that every other doctor looks at. But we also value that subjective data. How do you feel? You know, we don't treat the number, we treat you. So how do we work? Well, it's all about the team. So there's no way for me as a provider just to provide for the spiritual and the emotional supports for my patients. I do it sometimes, that's part of what I do, but I'm certainly not the expert. So in order to take care of somebody with a serious illness, it takes a village. So not only do you have your physicians or your nurses, but your social workers, your spiritual health clinicians, your pharmacists, your nutritionists, and your therapists, all the things you can think that you might need to add to your care to help manage your symptoms, to help you live with your serious illness, or to help you live and accept or learn how to maximize the time you might have with the illness that may be life-limiting. So where do we work? Well, we work where the patients are. So like, okay, I want to do palliative care. What kind of job can I have? Well, you see palliative care providers in the hospital. We are in ambulatory care centers, like outpatient clinics, like where I work. We do telemedicine and we go into people's homes. We're in the long-term care facilities. We're in the hospices, and we'll talk a little bit more about that. We're in insurance companies, believe it or not. Insurance companies are evil, but not always. Medicare Advantage plans are hiring lots of palliative care providers and nurses and experts to figure out how to deliver home-based care and Medicare and chronic and serious illness care to people at home, like my parents, Anna and Papa Curseen. Part of those plans are developed by palliative care providers. They're in the operating, right? They're palliative surgeons that just focus on doing surgeries to make people's lives better. And we live in these specialty clinics like oncology and neurology and cardiology, all of the other ologies where serious illnesses are. All right, Kim. So how are you different from hospice, right? So palliative and supportive care should be available to all patients to maximize quality of life through all the phases of an illness. Palliative and supportive care is not equivalent to hospice care. So what hospice care is actually an interdisciplinary program. It's an insurance benefit that is provided for patients who we are concerned may have 6 months or less to live. That hospice care is the way we deliver the palliative care a person may need at the end of life. Because when people are facing the end of life, in order for them to live fully in that place, they may need more support, like more nursing care, medical equipment, people coming into the home, doctor monitoring. So it's an expansion of these services in order to help keep people comfortable and maintain their dignity. And that's what hospice is. And hospice is the way we deliver palliative care to people who have a life-limiting illness, and we are concerned or getting close to the end of life. Palliative care can be provided no matter where you are in the spectrum. So for people like me, when they come to my clinic and they're actively getting treatment and they're either hoping to be cured, hoping to live with it, or to live as long as they can with it, they receive their palliative care through my clinic, through telemedicine, and through other means like in their specialty clinics. So how are the interprofessional teams different? And I think this is important because if we're exposing you to the profession, we want to expose you to the whole profession. So in palliative care, you have doctors and advanced practice providers, spiritual health, social workers, pharmacists, again, there of all kinds of therapists and other medications, but your medications and durable medical equipment, all of that goes through your regular insurance. If you're in your hospice care, there are doctors and spiritual health clinicians, nurses, certified nursing assistants, bereavement specialists, all the same kind of therapists, but under that hospice care, under that insurance benefit, it provides medical equipment, medications, and all that is paid by the hospice benefit, and it removes that financial stress from the patients and families. So really wonderful. So who gets to practice palliative care, right? So if I wanted to go into, do I have to be a doctor? Well, no, you don't. You can be a doctor, come to our side, but you can be a nurse, an RN, who we have the best RNs in the world working in our palliative care clinic. You can be advanced practice providers, so that's physician assistants and advanced practice nurses. Again, physical therapists, child life therapists, music therapists, many of them work in the area of palliative care. Pharmacists can specialize in palliative care. We have palliative care specialty pharmacists. We have spiritual health clinicians or chaplains who just focus in palliative care. Nursing assistants who focus in palliative care, again, dietitians, social workers, counselors, psychologists, community-based health workers. So these are lay workers that actually help educate people about palliative care. They help people do advanced care planning. These are volunteers within the community. They provide sitters or rides to hospital, all working for their community and providing palliative care. There's plenty of research. There's a whole body of research and research institutes that are looking at the medications, our care models, delivery, and then of course administrators like CEOs, all practicing palliative care. If you're thinking of medical school, what kind of medical specialist and their pathways to palliative care? You can get there as an internist, an internal medicine, family practitioner, radiologist, OBGYN, surgeon, pediatrician, psychiatrist, and rehabilitation specialist. So there's lots of pathways to get to practice the kind of medicine we do. And each one of these specialties often brings a special skill set that allows us to treat all different kinds of patients and offer them all different kinds of options. So in palliative care, the possibilities are endless. So I'd like to bring you back after giving you my explanation. I want to bring you back to the patients and, why would these patients see me? What would we do? So for a 30-year-old mother of three, with 3 children under 10 with advanced breast cancer who works as a pastor, we manage her pain so she can care for her children and still work, right? Your kids love you, but they don't care if you don't feel good. They just want, mommy to get dinner on the table and pick them up. So that still has to happen, even if she's going through treatment. We help her obtain family medical leave to accommodate her chemotherapy treatments and help her with that paperwork if it's really stressful. We provide counseling for depression and anxiety, which also accompanies serious illness. We connect her with a support group and support systems. We help her with resources for her children to figure out a way to even explain what is happening to mom. And that's incredibly important. We help her complete an advanced directive. We counsel her about medical cannabis. She's 30. It's a thing. We can talk more about that later. That's another YouTube session. Our spiritual health guide allows her to discuss her anger and frustration with God that this happened, because she's a pastor and she can't go to her other pastors because that for her would be really weird. She doesn't want to show that her faith is shaken, but it is. She's able to talk about the meaning of life. How does she reframe her faith? And then our spiritual health clinician guides her with meaning-making activities for her children, because if her disease does progress, if her life is limited, to help her prepare, what will her kids remember her from? 92-year-old with advanced dementia who's being cared for her by her only adult daughter. We explained to her daughter, dementia prognosis, and let her know what to expect. Because you can give somebody the diagnosis, but if you don't explain what it means, how much it's going to cost, how this is going to fit into their lives, you haven't given them a prognosis. You haven't told them much of anything. So we spend time sort of talking about, you have the diagnosis, what does it mean? We help her plan for her mom's ongoing care, just some practical things that she should consider. We provide caregiver support and resources. We help her complete something called a physician order for life-sustaining treatment. This is like an advanced directive that the daughter can do on behalf of mom, because mom no longer has the capacity to fill out her own advanced directive, but the daughter does know what her mom would have wanted. So this way it's written down, I say in doctor language, so we can honor her mother's wishes. We manage her mother's pain and agitation. We again assist with family medical leave. And we complete the forms to help her access her long-term care policy to relieve the financial stress from her daughter. And we also look for caregiver grants. I'm pretty sure that you've had other sessions which sort of talked about caregiving and how much that costs. There are billions and billions of dollars, so much unpaid work. So it's a blessing to be able to take care of your family, but it can be financially devastating. So we pay attention to that. We think about that. 55-year-old with diabetes needing a heart transplant has constant burning in his feet, and he's currently homeless. We help him find stable housing and address food insecurity and work with community caseworkers to try to do that. So this is the importance of having community-based palliative care who kind of understands the systems. We help manage his pain and other symptoms. We help him find a primary care provider to manage his diabetes. Because although we specialize in symptom management, we can identify what a person needs and we get them to their specialist that can help them the most. We advocate for him with the heart transplant team to make sure his wishes are known, that he has a voice as they're trying to make these decisions, and he's making these decisions. We build trust with him and help him connect with family and identify a healthcare agent, which is going to be really important. He has a serious illness. Who's going to make these medical decisions? We assist him with mental health resources. We help him complete an advanced directive, and we offer something called dignity therapy. And this kind of therapy, he's able to narrate his life story, and we get that narration back to him. And that can be really meaningful. So if you ever have an opportunity to Google dignity therapy, Google it, because it's amazing. But it can be really meaningful. And he has the opportunity to keep it for himself or to give it to someone who he loves. But this is a way for him to mark that he was present. And this is a way for us to let him know how important he is and that he's not just lost, he's not alone. And that his life is meaningful and valuable. And 5-year-old girl with aggressive leukemia being raised by, I said girl and I said his grandmother. Sorry about that. We provide pain and symptom management during her treatment. We provide support for grandmother and to keep her informed because it can get a little confusing, all the medical terms. We discuss possible outcomes. We validate hope, but we also start to help grandma prepare for the worst if things don't go like we hope. We advocate for her and her grandmother's wishes to make sure we're following and the treatment that's being offered is congruent with values. We have throw a birthday party in the hospital and we bring in real princesses because that's just what we do. We manage symptoms after the treatment's over, because just because your treatment's over doesn't mean you're well. So this is a really important point. When we're managing somebody and we're managing them in a serious illness and they get better, or the illness is cured, that's all that means. The treatment for any illness is just the only thing that can offer you is the promise of life. It does not offer you what that life is going to be like. And so sometimes that's the chasm. So you might see us still be involved with somebody when the treatment has completed, because they're still not well and they're still suffering and there's still all these symptoms. And it takes time. We manage the symptoms and we help her reintegrate back into her life. So hopefully eventually she doesn't need us anymore for a time. And we still remember her birthday, and she remembers us as her elementary school graduation. So I just like to say, just in closing remarks, that I love what I do. Why do I do it? Because in this profession, so many things go wrong all the time. But if we do our job right, this is one of those times where things go exactly like we said they would. It was as advertised, and we make things go right. And when others say no, and when other people leave and worry that there's no more they can do, when they see us, we never say there's no more we can do. There's always something we can do. Even sometimes if that's just sitting and being, there's always something we can do. So I think I do it because it brings me immense joy, and it makes me remember why I wanted to be a doctor, and it makes me remember, how beautiful humanity can be. So with that, I'll close.
Well, first of all, thank you so much, Dr. Curseen, for all this. This was first of all, like I said at the beginning, this is the first time many of our students, this is the first time in general that we've seen this specialty, and many of our students may have not even had any exposure with palliative care. You mentioned the divide between palliative care and hospice, which is especially important because sometimes lines are blurry. I think we can hit off with our first question being, I think you touched upon this a little. In this specialty, it's actually good that they wouldn't have to see you anymore, right? Because that would signify that no longer the need of this type of care. But with that said, how do you describe your boundaries with emotional connections to patients?
That's a really good question. I think one of the things that I've learned after doing this for a long time is that when I'm with patients, what is happening to them is happening to them. So I say, what I am is an extra in the movie of their lives, right? I'm not the star. So when I'm with a family and things aren't going well, and there's a tremendous grief, it's not that I don't feel it, because I do. And I have the empathy, but I respect them enough because that is their grief. That's their moment. And it's not for me to take from that, if that makes sense. Because when I walk out, I'm fine. I go home to my husband and my beautiful boy. And one day it's going to be my turn, and I'm going to be the star of that show, and somebody will be caring for me. But that, I think when we start to blur those lines, or we start to think that somehow what we're doing, or we're wanting something from our patients don't have a lot to give. So I think you have to kind of go into the mindset that this is, you're giving out, and what fills your cup has to come from someplace else. And that your job is to mitigate the suffering, stand there with them. But this is their time, and we are the supporting cast in their life.
I know you mentioned that we probably would need a whole entire session for this, but you did mention some cases where you might need to counsel patients about medical cannabis. So is it possible that you could possibly just elaborate just a bit during this session on what that counseling would look like and how it differs from other types of counseling?
Oh, that's a really good question. So in palliative care, we work in symptom management. And so many patients are, and we can't deal with what, things should be. We have to just deal with what is. So if I'm going to meet you where you are and you're using medical cannabis and you want to use that for symptom management, then I need to know something about it. And so how the counseling goes is I sort of explain it. I break down what marijuana is, the parts, why it might be helpful. I talk to patients about the literature. I talk to them about the medical risks. I look through their medications and look for drug interactions. And what I'm wanting them to be is informed. Sometimes, there's a lot of things out there on the internet, such as medical cannabis will cure your cancer. And that's hard. So when people believe that these things are going to provide cures or sometimes misinterpret about what they can do, it's up to us as medical professionals to be there to sort of level set that, sort of inform people of what the evidence is as they're making decisions and try to cut through some of the noise. But yeah, I think that if you're going to do something, I rather know you're doing it. I rather be a part of it and make sure that it's safe, that you're safe, and that you're, going to get the maximum benefit out of it.
So you, along your journey, have 3 board certifications. With the position that you are in now, how do you feel like each contributes to your level of care? And as a palliative care physician, which ones would you feel are most needed?
And this is just going to be my bias, but I was really fortunate as an internist and a geriatrician, and I practiced a little bit before I went into the field. So in order to understand how somebody is either living or dying with an illness, you first have to understand what the illness is. You can't palliate something you don't know anything about. So you have to understand dementia, you have to understand cancer, you have to understand the difference between what is sick and will get better and what is sick and will not get better. And that only comes with having a good concrete knowledge of the illness and how things go. You also have to understand physiology and pharmacology. So I think as an internist, I was really fortunate to have a wonderful training program where I got a really solid education in the physiology and the understanding of, major medical illnesses. As a geriatrician, I really got to understand pharmacology. I got to understand delirium and some of these other complex issues around frailty and around function and how function affects prognosis. So when I put those together and I added palliative care, that really set me up to really understand how to do my job well. But yeah, you got to understand the illness, or you can't figure out how to make people feel better.
Absolutely. You also mentioned, you talked a little about faith there earlier, especially with one of the cases of a mother being a pastor. So in the case of, let's say, the situations where palliative care conflicts with someone's faith or beliefs, like for example, some faiths may believe that pain should not be masked if it's a punishment by God, right? It's something that they are deserving of for whatever reason, and they should not be taking away from that because it's justified. In those situations, how do you handle them?
So you ask a really good question. So if palliative care, if the tenet is that I am going to help you reach your goals and that the care is concurrent with your values, then there's no faith tradition that is in conflicts with palliative care. Right. There's faith traditions that might conflict with what I want for you. So palliative care is for me to help give you what you want for yourself. Palliative care is not for me to give you what I want you to have, because what I want you to have is awesome. So in cases like that, as painful as it is, my role may not be to mitigate that pain. My role is then to tell everybody else who's freaking out about it that this is what you are choosing to do. My role is to give you an out valve if you say that you want to have that treatment. And my goal is to try to figure out what other parts of suffering can I mitigate for you to make your life more pleasant, to allow you to walk through that journey. And then sometimes my role is just to sit there with you while you're suffering and not leave and bear witness to it.
Yeah. Another thing about pain medications. So with managing pain, not only do they like mitigate that pain, but also at times they would be able to affect the consciousness level of a patient and maybe their ability to function or concentrate, which might affect their decision making. Does that ever come into play? Is that something that presents as a problem sometimes?
Oh, this is a really good question. So we have we have what we call things of last resort, where we've done everything we could to get somebody, as comfortable as possible. But the suffering's too great, the pain's too great, the agitation's too great. And there are times where we palliatively sedate someone. The goal of palliative sedation is not to take someone's life. The goal is to treat the symptom, and we medicate only to treat the symptom. The effect of that is that they're not conscious, but that's not the primary goal. And usually we've tried everything beyond that. Many of the medications that we have available to us can affect people cognitively. So what we do, we're very careful about what we prescribe and very thoughtful about it to try to balance. And once we see that patients are having cognitive distress, to really pull back and see what else we can use. So I think that, but it is very hard. The other problem is that if a person's not doing well and the body's dying, the way they manage and metabolize these medications become different. And actually your level of consciousness, if we don't manage anything, becomes different. So what the medications do, they're not really affecting, your life. They're not almost sometimes affecting your level of consciousness. What they're doing is treating the suffering. If you remove the medication, all you would see is suffering and still an altered level of consciousness. So, and then you also have to be careful and make sure that you are not looking for reversible things that you can do, that you're choosing the medications correctly, that you're providing the support around the medications that you're offering to make sure that people can be as clear as possible. So that's a very long question, but long answer. So I hope I answered that, but.
Definitely. That raised another question. So, I mean, there's a lot of ethical decision making, I guess, within this field. You mentioned, for example, like a cardiologist, they're going to treat heart failure, but you would treat the shortness of breath. So it's a different take on things, right? Same thing for ethics, and definitely another more emphasis on that. It's just more common. So with that said, are these ethical decisions always put on the physicians to decide? I remember hearing about ethics committees at and boards.
No. Yeah, absolutely. It is so good that these decisions are just not left up to doctors, because you have to remember, we come with our own set of values. So our white coats aren't magical. We come with our own set of values, our own biases, our own religions. We bring all of that into the room. And when things are tense and stressful and the ethics we're not sure of, it's really important that we rely on our ethics committees, that we don't make these decisions alone. And ethics committees, most hospitals will have them, and they'll, if we're fortunate, they'll have an ethicist. You may have other physicians there who have a special interest in ethics, maybe people from spiritual health or administration. And they sit down and they really give thoughtful, objective ways to evaluate a case. And then they bring that back to us. So even as a palliative care provider, I am a holistic provider. I am trying to honor the wishes and the goals of my patient, but I still have a point of view. So just to leave it up to us to be the end all and be all is not appropriate. So I always think in times where you're not sure and they're ethical questions, never be on an island alone. You got to phone a friend, and you have to be in a place to allow your point of view to be challenged and to see if it still holds up. and it still holds muster.
You had a few pediatric cases along with adults. So in terms of bedside manner, how do you approach pediatric patients versus adult?
And this is a good question. And I'm not a pediatrician, actually trained as a geriatrician, but when many moons ago, when my hair was still dark, I worked as a medical director of a hospice, and children were there. So I had to see children. Children are amazing. They're very resilient and they live in the moment. So if they don't feel good, they don't feel good at that moment. And if they feel good, they feel good at that moment. And you're like all spinning out, oh no, it's so terrible. They're like, I'm fine. Get out the way. I'm playing my Nintendo Switch. So I think it's important to be able to meet children as where they are. It's also important, as I think, as children are maturing into young adults, to make sure that you're figuring out a way to take their wishes into account and having conversations and respecting their personhood and dignity. Because, the kids, even though they may not understand everything and they can't consent, they do have a sense of self and being able to allow them to have their voice in a supportive way. Also with parents recognizing they're coming from a very emotional place. This is, the worst thing in the world is happening. And we have to be patient and kind and ready for, the uncertainty and that kind of emotional roller coaster. So, that would be my general approach. Be open, be patient. If I'm doing a consult, I'm probably not going to get an answer right away about what their goals are, what you want to do. This is going to take time. This is a process. So you want to make sure, and most like pediatric hospitals, they're amazing. If you're not working in one of those hospitals unless you're kind of patient and kind, but every once in a while, it does help to have us sort of slow those things down, advocate for patients, give another point of view. And also I think my pediatric colleagues spend a lot of time helping their colleagues sort of deal with some of the grief and some of the emotions that they're feeling, and tending and supporting the medical team through situations that are difficult. So sometimes we're not just supporting the patients, but sometimes we're supporting our colleagues in these very difficult emotional situations.
And then in terms of family members being involved in the care process, how much do you kind of keep them within that close circle of exactly, what's going on? And does that vary based on how close the family member is to the patient?
Absolutely. The patient gets to decide who they want in their circle. But what I explain is like when you get sick, right? And we say, hey, we're going to do what you want, and you're the patient and you're the most important person in the room. Well, that's true, but there's asterisks, because whatever you do and you decide, everybody else around you who loves you has to participate and be complicit in it. So to behave as though when we are only treating the patient and we only consider what the patient wants and their feelings, well, that's not how the world works. That's not how family works. We're interconnected. So what we try to establish is what's important to the patient, and then what is important to the family. And then with the patient, how important is the family's wishes to the patient? So we see this all the time where maybe a person might not want more therapy. They just don't want it. But their loved ones want it. And so they do it. And then we see, the healthcare providers be all up in arms like, this person didn't want this. Why are they doing it? They didn't want this. The family's making them. So if we step back and reframe that, if I'm sick and I have a life-limiting illness, I may not want a lot of things, but I have a 6-year-old son. And if he says, Mommy, I'm not ready for you to go, then I'm going to take 20-line chemo, not because I want to, and not because it meets my goals. It's because I do love myself, but I love him more. And if you're going to honor me, then you're going to help me do this and make it not suck. You're going to try to palliate within the confines that I gave you, and know that me doing this is how I'm honoring, that's how you honor me. because, you help me, you help my son. Does that make sense?
Yeah, it does.
Yeah.
It's very, I mean, the more you talk about it, the more I see how much of an intimate specialty this is with patients.
Mhm.
Like, I mean, I've never seen such a very, like, it's so vulnerable. All patients will be vulnerable with their doctors. They're going to reveal secrets and tell things that they would never for anyone in any specialty. But this is extremely intimate and vulnerable. So it's just amazing to see. I just wanted to circle back to the ethics committees that we were discussing earlier. So how do they go about making selections? What are some factors that they look for members who join these committees?
That's a really good question. So many of these committees are voluntary. And so most hospitals, if they're able to financially afford it, will have ethicists. And so those are people who are hired to do this. And then they bring about committees mainly by people who are interested. If they have a lot of people, then they may do interview processes or selections. Many of the people will have a background or an interest in ethics before they come, if that makes sense. So every hospital does it a little bit differently. Some people might even have like community or lay people on their ethics committees. But if you're interested in joining an ethics committee, like if you're interested in going into medicine and that, it would really be worth, just contacting your local hospital and asking. They're usually wanting people because it is a tough job.
Also, for patients who make a request to receive care from home, how do you go about organizing that? Is it often through telehealth? And before telehealth, what protocol would be taken to make that possible?
Oh, that's a really good question. So when a patient is at home, there's a lot of ways they can get care. So if they're entering into home hospice care, the way that's provided is like any other service or agency. So hospice care, hospice companies are all within the community. And we as a physician can write an order that certifies the patient's appropriate. The medical director of the hospice, based on what they read and their understanding of our notes or their evaluation of the patient, certifies that they're appropriate. And we write a medical order and the agency comes out and continues to see patients in the home. We provide palliative care in person and by telehealth. Before, our institution had embraced telehealth like some others. So patients were coming to the clinic, or we did a lot of work by the phone. Once telemedicine happened, I work in Georgia, so that really opened up a whole new world. So, I work in Atlanta, but, Georgia's a big state. A lot of that state is rural, and a lot of that state has, people who really struggle financially and economically with transportation. So the ability to be able to do telemedicine to provide this care has been wonderful. First, like control medicines, we need to see people in person, but it allows another option to establish care and to continue care. And it's really cut down on some of the burden for our patients. So it's been really wonderful. During COVID, many of the hospices provided telemedicine because the families didn't want them to come in, and they walked patients and families through. Spiritual health clinicians and nurses and social workers visited with people by telehealth. And now many of them, that's just how they do it.
Yeah. The pandemic's made lasting impacts even afterwards.
Oh yeah. For medicine, it really revolutionized, it moved us forward to a place we probably were going, but really needed to get to. So it'll be interesting to see how these virtual platforms end up in the future.
Yeah, things like virtual shadowing too. I mean, that's how this all popped up too.
Oh yeah.
But I wanted to ask, where was the beginning of palliative care? Like, what's the history behind it? How did this all come into a specialty of its own?
Oh, that's really, so that, it started off initially, there's several places it started, but we often think of the grandmother of hospice care, Dame Cicely Saunders in the UK, opened the first hospice and sort of developed the model of how you think about whole person care, the model of how you think about pain. And then that was transferred over to this country, and we started to adopt that model. And then we had really great leaders, like Diane Myers, started to think about palliative care and how we could spread that and go move beyond just taking care of people who are at the end of life, but moving that upstream, and how do we take care of people who are on the in-between. And there are some other famous people that I'm blanking on now, just because I'm older, and I'm so sad that this is I'm gonna get so much non-love for not naming, like, going through the history properly. But
Yes, definitely. At this point, I personally have got a lot of insight into palliative care. I personally volunteer at a local hospice, and this has been such a great insight. Maybe we can end off on one more question to wrap up today's session. So we talked about the history, but what about the future of palliative care? Where do you see this going? Do you see an even heavier emphasis on telehealth? Do you see potential areas for further subspecialties, further fellowships? What are the advances looking like?
yeah, you asked a very good question. I think we're starting to go through a metamorphosis like every field. And so palliative care really, first was able to break into the hospitals. We broke into the hospitals and we were providing good consults. And we always had outpatient, but we really focused on that hospital care, the sick patient, the ICU. Now we're realizing with medical advances, and it's becoming so much better. The hospitals, people doing a much better job at really talking to their patients and managing symptoms. We're realizing now we're having to think about downstream and people living longer. So I think the outpatient is growing, how to manage people with serious illness who are going to live longer with these illnesses because the treatments have gotten better, the advances have gotten better. So if you have a serious illness and they can keep you alive longer, that's fantastic, but that gives you more time to have symptoms. So really thinking about how do we provide this care to an outpatient, and how do we make a sustainable model? Telehealth, I think, for us is here to stay. And I feel like that is going to be one of the major drivers of how we deliver the equitable care across the states. I also see us, and I see our other health professionals, just beyond doctors, our advanced practice providers, our social workers, really, taking the lead. And the next big frontier is Medicare Advantage programs, who are really thinking critically about how do you manage serious illness and how do you take the principles of palliative care and developing care models that are covered within those Medicare Advantage programs, which are just insurance programs, to provide, comprehensive care for people. So I think we may be, as our care models slowly inch towards moving away from fee for service, and we're really thinking about how do we manage populations, how do we make resources go further, how do we reach people where they are. I see us as being more thought leaders and designing how care should go. And that's an incredibly important way, because in my clinic, I help one person at a time, and that's my jam, and I love it, and I'm never giving it up. But we also need people who think like me, helping lots of people at a time. So that's where people working in population health, in the assurance companies, doing that research in public health. That's, people with this kind of thought process in those spaces can make huge differences to make people like me do our jobs better. So thank you, Michael. Go forth and do that. That's all you have to do. Just
Wow.
that small thing. Just that small thing.
Just that.
That's it.
Take me more than tonight.
Yeah, I'm sure.
But wow, this was such a great session, Dr. Curseen. I have to say, I'm so glad we had you on to talk about this. I personally learned more than I think I would ever have learned if we did not see you in today's session. And I think a lot of our students can say the same. So just a few reminders, but let's hear some thank yous in the chat for Dr. Curseen. What a wonderful session today. I'm so glad that we had it. But just a few reminders to end off today's session and wrap up. To those who are listening and to those who are seeking out credit for your attendance today, you must pass the quiz, which is now posted in our chat box, the same place that's either to the right or bottom of our video and live stream here, or on our virtual shouting page, which is on our website. So if you go onto our virtual shouting page, click on it, and then you would scroll a little down. You're going to see a Monday and a Thursday quiz. Today's a Monday, so you'll click onto the Monday quiz, and this quiz will be due later this week on Sunday, November 27th at 11:59 p.m. Central Standard Time. So just be sure to complete it by then. And once you do pass that quiz, like I said, you will receive a certificate. It will be sent to the email inbox of the address that you list on the quiz. So be sure it's one that you're comfortable with. We recommend a personal Gmail, Yahoo account, personal email in general, because school emails typically filter them out. And if you don't receive that certificate either to your inbox or to your spam folder, please shoot us a message. Again, our email is shadowing.h4h@gmail.com. Our next session, we're not going to have a session this Thursday because that is Thanksgiving, wishing everyone a happy Thanksgiving. But next week, we will have our sessions resume. We're going to be joined by Dr. Rodriguez. He is the director of St. Jude Global and the chair of the Global Pediatric Medicine Department at St. Jude's Children's Research Hospital. So I know we have a lot of enthusiastic future pediatricians out there. We always hear it every session. So that's definitely one for y'all. Like I said, it's going to be next Monday, November 28th, 7 p.m. Central. We usually operate around a Monday and Thursday schedule, so you can just keep that in mind, but sometimes it does differ. Actually, next week, we will have 3 sessions, Monday, Thursday, and Friday, so be sure to look out for those. Again, post on our Instagram and listserv if you'd like to check out more details. But with that said, that's really all. I want to thank Dr. Curseen again so much for your time today. It was such a joy. But yes, I'm hoping everyone to enjoy the rest of your week. We'll see you next week.